Welcome to ADAPT NCLEX. Thank you for deciding to join us. Welcome to our Patient Prioritization Delegation NCLEX Review Part 2. First question, what do you think? This is what's been given recently to students, nurses. They see these questions and they're running away from it. A nurse in the medical surgical unit is caring for what? 5 clients. Which client should the nurse assess from first to last? That means you got to arrange them from first to last. What do you think? First patient, you have a client with epiglottitis who is drooling and has inspiratory what? Stridor. Think about that patient. A client with a heart failure who report sudden weight gain of 4 pounds in what? 24 hours. What do you think about it? A client with what? Hypoglycemia who is diaphoretic and report shakiness. A client with what? Parkinson's disease requesting assistance with feeding breakfast. And the last patient, a client 1 day post-op hip replacement who needs what? Assistance to the bathroom. 5 patients. This can be a case study and they'll ask you to arrange them from who do you see first, second patient, third patient, fourth patient, and fifth patient. And then they're going to ask you questions about it. What is the major problem about each of them? Don't worry. Ignore the table, the box, the number of patients. Assume as if this is a patient. All of them are priority, like I say all the time. But who do you want to see first? The heart failure patient who have a sudden gain in weight, epiglottitis patient who is drooling and has inspiratory stridor. What do you think? Those are all buzzwords. Or somebody who's post-op day 1, hip replacement, want to go to the bathroom. Parkinson's disease is requesting assistance with what? Breakfast. And I have hypoglycemic patient who is diaphoretic and reporting shakiness. Who do you want to see? You have 1 second. You got to be sharp. Who is in trouble? Who you don't have time with? What do you think? If you know it, arrange them the order you will see them. And let me think. Put it in the comment and let's take a look at it. But as you can see, there's some bad things going on with each of them. But one of them is in trouble. Who is in trouble? As you can see, a epiglottitis patient is the patient you're supposed to see first. But then who do you see second? Now, you have to prioritize. There's a reason why NCLEX love prioritization is because it tells them you can critically think, you can see who is in trouble, risk reduction, and so that you can fix their problem before they get into trouble. Do you think a heart failure patient should be seen or hypoglycemic patient? Do you think the Parkinson's patient or the patient is post-op hip replacement? I think the hypoglycemic patient is in trouble. The heart failure patient, you have a little bit of time. Hypoglycemic patient with diaphoretic and shakiness, patient is in trouble. You need to see that patient and then take care of it quickly. Then you go and see the heart failure patient with a sudden weight gain, 4 pounds in 24 hours. That is going to go into pulmonary edema. Right now, I did not give you any symptoms. I just told you there's a weight gain. It's a problem. There's no pulmonary symptoms right now. There's no pink-fluid sputum, right? But number 2 is having symptoms, shakiness and diaphoretic, telling you, I'm dying. Save me, nurse. 1 is something that is your anticipate problem is going to happen. And of course, always, you got to take care of the post-op patients before the Parkinson's patient. 5 patients. I want you to keep on doing this. Even if you're doing prioritization and you have 4 patients, arrange them, pick your right answer, then see who should be the second, third, fourth. Read the rationale, where you're taking the question from, and see if they give you that idea. But this is the case studies they start giving to people. So I'm trying to practice you so that when you see it, don't run away from it. Just step back, arrange them based on priority, and figure out who that need to be seen, and you'll be golden. Now, usual prioritization. 4 patients. Who do you think we need to see? Let me show you how to read it. Don't worry about it. Always read it so that you can understand it. If you want to read the full sentence, fine. But this is the way I do. I divide it into 2. And I go for the buzzword. Clients, I don't worry about you. I think about aortic stenosis. What is the problem with aortic stenosis? Chest pain. Is this what is going to happen when you hear aortic stenosis associated with chest pain? Does that make you feel comfortable? You have to be sharp. The Jackson therapy. What is the problem? Nausea. You have to be sharp. That means what? Breathing, shock, sepsis, electrolyte, pain, and pain that is going to affect your life. So this is what I mean by that. Check my YouTube. You see a bunch of prioritization. I'll give you amlodipine. You have facial flushing. You have hypertension. You have mild headache. What do you think? Put down your comment and let me know. Put down your answer. Think about it. And then go back and tell yourself, you have 1 second. Who do you want to give it to? If you have hypertension and you have headache, well, mild, I put mild here. I really mean it. Mild headache. It's not urgency right now. Amlodipine is a calcium channel blocker. I expect facial flushing because of what? Vasovenous dilation. Ignore it. It's not allergic reaction. The Jackson is toxicity, right? I'm very toxic with the GI symptoms. I'm worried about you. Aortic stenosis, you have chest pain. I'm worried about it. You have two people you got to worry about. Like, who do you think you don't have time? Then you got to bring your content. You say aortic stenosis. If this is the aorta, there is stenosis here, right here like that. If there's no blood flow, I'm in trouble. And how do I get chest pain? It's because there's no blood flow. That means there is complete blockage. This is going to lead to what? Sudden heart death. And therefore, that patient, number one, is in trouble. Even though the Jackson is a toxic situation, this guy has no time. He's going to die right now. Chest pain, shortness of breath, aortic stenosis should be your prioritization that you got to pick them. Or exertional chest pain. Watch for that. Key concept. Number one, aortic stenosis. Write it down. Number two, same thing. I want you to divide it into two and then figure it out. I guess it's number three. A client with asthma, what? With the peak flow of what? 45. What do you think? A client with what? COPD, shortness of breath when you're walking. I have croup and I have backing cough. I just have my gallbladder removed, cholecystectomy, and I have shoulder pain. Bring your content. Relax, step back. Don't have a tunnel vision. Open, look at it, each situation, analyze them, then figure out what is the problem. If you have gallbladder and we remove your gallbladder, there's gas. Sometimes you get referred from irritation of the diaphragm. You're going to have shoulder pain. Croup, there's no croup patient who has no backing cough. Therefore, you know it's an expected finding. It's not having, unless there's retraction or intercostal retraction, and having severe stridor, yeah, you got to worry about. COPD patient, shortness of breath. But when you're walking, well, then take it easy. That is an expected finding because when they walk, they exert themselves and they have problems. I'm not worried about you. Asthma, peak flow of 45, any peak flow less than 50, it means you are in the red zone. If you are in the red zone, you need to take albuterol and you got to go to the emergency room right now. Concept, content, using NCLEX practice question, prioritization, patient prioritization strategy to be able to answer this. You have to be comfortable with prioritization and don't have tunnel vision. Always fall back to your B-sharp moment and ask yourself, if I have 1 second, what would I do? I'm picking an asthma patient over you. Next question. Number 4. These are endocrine patients, 4 of them. If you know your answer, just put it in the comments and let me know what you think. 4 endocrine patients. 1 is taking metformin and there is dark urine and muscle pain. 1 has hypothyroidism and confusion. 1 has diabetes insipidus and I have excessive urine output, polyuria. I have type 2 diabetes whose fasting glucose is what? 140. Same strategy. What do you think? I know you got it because you watch ADAPT NCLEX. These are your endocrine situation. Metformin, I have dark urine and muscle pain. Hypothyroidism, I have confusion. Diabetes insipidus, a bunch of urine. Type 2 diabetes, my glucose is high with fasting. Does any of these concern you? Does it bother you? Does it worry you? Then you step back, you ask yourself, why would I have to worry? I mean, this is just, they're giving me the answer. It popping out like a candy. Type 2 diabetes patient, well, I don't expect your glucose to be normal when you fast. Therefore, I'm not worried about you. Diabetes insipidus, it means you have no what? ADH, and therefore you're going to have a lot of urine output. Excessive urine, this is what I expect. Of course, you're going to get dehydrated, but this is what I expect is going to happen to you. Hypothyroidism patient, he has confusion. What do you think? I know things are supposed to go down, but when you have confusion, you have something we call mesoderma coma. Metformin, you have dark urine and muscle pain. You probably have lactic acidosis, and you may have probably rhabdomyolysis. But who, 1 and 2, who do you think is in trouble? Mesoderma coma versus rhabdo. You have to know that hypothyroidism is the biggest problem with confusion. Mesoderma coma, they're going to have bradycardia, they're going to have confusion, they're going to have airway issue. Therefore, I'm picking number 2 over metformin having lactic acidosis. Number 2 is your biggest problem. This patient may need to be in the ICU, airway problem, and we got to take care of it. So far, what is your score? 4 out of 4. I know you got it. This is the things I want you to guys think about when you're doing prioritization and try to master them. Don't worry about it. Now, let's look at delegation. Delegation, when you see a UAP, a nurse is planning care for a group of clients and considering tasks that can be delegated to a UAP. UAP, what I say is don't pick any answer that requires thinking. If it involves activity of daily living, pick it, right? That's all. Those are the things that they can help with the patient. If you require some assessment, evaluation, teaching, and everything, ignore it. Therefore, what do you think? Obtain vitals for a client with hypertension. Can a UAP do that? Think about it. Put down your answer. Let's think about it. Assess the client with Alzheimer's disease to the what? Bathroom. You are just assisting the client. He's going to the bathroom. What do you have to require a bunch of thinking? They're feeding a client, the patient at what? Dysphagia. What? Who has just started on what? Mechanical soft diet. Think about it. 3 questions. Performing a postmortem care for a client after the RN has pronounced dead. The RN has pronounced the patient dead. Can the UAP go and perform postpartum care? You collecting a clean cut urine specimen from a client with a suspected UTI. Do you think a UAP is allowed to do this? And performing initial teaching on incentive spirometer after abdominal surgery. I'm trying to bring your brain back and think about little things that they may ask you. What do you think? And turning and repositioning a client at risk for what? Pressure injury every 2 hours. We already talked about it. Activity of daily living. Do you see any activity of daily living? Yes, I see. Number 7. It's an activity of daily living. I'm just basically helping turning the patient. I'm not doing anything. What else do you see? Activity of daily living. What do you think? What do you think that it requires activity of daily living? Assisting the client who has Alzheimer's to the bathroom is activity of daily living. And of course, I can check your vitals if you have blood pressure problem. You are not in shock. Feeding a patient who has dysphagia just started mechanical soft is not safe. You got to figure out if the patient is safe. So the RN has to take care of it. How about number 4? Think about it. 4 and 5. What do you think about these 2 questions? What do you think? Can the UAP be able to do that? There's a clue in the question. Number 4, even if you don't know whether they can do postpartum, use test taking strategy. I said after RN pronounced. So after the RN has done the initial assessment, the UAP is allowed to help with the postpartum care, postmortem care. And this is always a trap. Plain catch urine is always done by the patient, right? It's not a story. The patient usually go to the bathroom, they give him the cup, and they do a clean catch, right? They go and then you tell them to take the mainstream, right? Therefore, UAP can direct them. He can give them the specimen and they can use it. So they can do that, right? Initial teaching for incentive spirometer, negative. So these are the things that you expect a UAP will be doing. Delegation 101 made easy. What is your score so far? 5 questions. I know you got all of them right. Number 6, a nurse is caring for 4 renal clients. Now I take you to kidney, right? There's a kidney concept, nephrology concept that is good to know, right? Med-surg right there. I have nephrolithiasis, a big word. What do you think? It means kidney stone. And you have frank pain. Should you have frank pain with kidney stone? You see the way I'm interpreting the question. That's the way you do it so that it makes prioritization easy. I have glomerulonephritis. That means inflammation of the glomerulus, where there's going to be blood. You're going to have edema, periorbital edema. Is it a big problem? I take enoxaparin and I have frank pain and a bruising. What do you think? I have nephrotic syndrome and I have what? Protein in my urine. Should this concern you? For renal patients, what do you think? Bring your content and say, I've given you the answer. You can see the answers are there. Lithiasis, stone, is supposed to give you frank pain. Nephritis, well, you're going to have some tea-colored urine and you can have periorbital edema. Enoxaparin, of course, you can have frank pain and bruising. But what do you think is that? Nephrotic syndrome, you lose a lot of protein in your urine. That is a problem. The major priority for this is hypertension. This proteinuria is okay. As soon as they have hypertension, you worry about it. But if I give you enoxaparin, think about it. You can get bruises around your umbilicus. You can get bruises along the frank area. These are major retroperitoneal hemorrhage. You have gray tenosyte and curling sign. This is a major problem. This patient is bleeding. Number 3 is the patient is supposed to see. 6 questions so far. So I'm making an announcement. I've received a bunch of emails about live class. So if you're interested, I want you to email me. I have some time. If not, I just want to know how many people are interested. So I'll put my email in the description, and you can email me and see if you're interested. And it will be like September 13th to 23rd. I just want to know how many people want to attend. I have other things to do, but I can make myself available. This may be probably the last class for a long time because of work obligation. Which neurological client require priority care? A client with what? Myasthenia gravis, who report what? Blur vision. These neuro cases sometimes can be confusing, and they can try to trick you with so many words. I'm going to give you the key information. Multiple sclerosis, reporting about what? Dysarthria. Migraine, treated with what? Sumatriptan. Old stroke patient, now with the slurred speech. Which 4 of these patients should make you worry, should give you a buzz when they come to neuro patient? There's a key word you have to know. Myasthenia gravis, they said I have blurred vision. Multiple sclerosis, dysarthria. Migraine patient being treated with sumatriptan. Old stroke, I have slurred speech. If you have to see any of them, who would you see first? Let me know. Put down in the content, in the comment area, and let me know. Who do you want to see? What do you think? Arrange them and then figure out who is in trouble. Of course, number 3 is fine. What do you treat with migraine? Sumatriptan. Don't pick the stroke patient. I said old stroke. Stroke patient supposed to have slurred speech, and I put mild there. It's not the new stroke. Myasthenia gravis. They're going to get tired throughout the day. They are stronger in the morning, and in the evening, they're worse. They're going to have blurred vision. But as soon as they have airway issue, it's your priority. Multiple sclerosis should not have dysarthria. If I see dysarthria, it's the airway. So for neuro patient, what do you want? Whether it's Parkinson, whether it's multiple sclerosis, whether it's myasthenia gravis, any neurological problem, whether it's GBS, whether it's ALS, always look for what? Dysphagia, dysarthria, swallowing problem, or speech. That's all you're looking for when they give you a prioritization. Any other thing is an expected finding. Therefore, a multiple sclerosis patient with dysarthria, I have a problem. I got to see number 2. That's your right answer. Another delegation and with LPN. You know the thing already. Now for LPN, there's a strategy. It's called MMR most, right? This is the way I write it, MMR most. That means most medications, monitor, reinforce, I can take care of the stomach, I can do 2 feeds, and any other medication. That's all. You don't have to make it difficult. You don't have to do a bunch of lists. This is what I said as everything that you know for LPN delegation. And therefore, what do you think? COPD patient, you need a scheduled inhaler administration. I just said most medication. Most medication means most medication. And COPD patient who need inhaler is okay. It's acceptable for what? LPN to take care of. Number 2, 2-hour post mastectomy, right? Requiring the word initial wound assessment should give you a pause. Diabetes, who need what? Routine insulin administration and blood glucose check. What do you think for LPN? New onset confusion and fever requiring what? IV antibiotic. What do you think? On warfarin therapy, who need education about dietary vitamin K. What do you think? And the last patient, hypertension, who require reinforcement of what? Medication adherence. I said MMR most medication, reinforcement. They don't do teaching. They can give most medication. They can take care of the stomach. They can take care of 2 feet. What do you think? First patient just need what? Medication for COPD. Inhaler is okay. Initial is not okay. The nurse has to perform the initial assessment. Insulin is a routine medication. It's not a bad thing, right? But somebody who have confusion, he has fever, I don't think the LPN should take care of that, right? Warfarin, fine, need what? Education. I don't think the LPN should do that either. And hypertension, the word is reinforcement. So the LPN can do that. It can give glucose, insulin, and it can give inhaler. You can see strategy to answer this delegation and assessment and prioritization straightforward. Number 9, a nurse is assessing for maternity client. Now, this is maternity. Look at it. I did not make it too difficult, but I try to let you know these are buzzwords you have to look at it. Look at what I've said. Pregnant, 14 weeks, I have headache, and it's severe one. I'm postpartum. My uterus is very firm at the umbilicus. I'm laboring clients. I have early deceleration on the monitor. What do you think? I'm post-op day 2 from a postpartum. I have clots and local rubra. Maternity nursing, you have to master maternity and peds. These are high yield facts for the NCLEX. They're going to ask you maternity. If you have a problem, videos you can watch that will help you. But this is maternity 101. Pregnant lady, 14 weeks, have headache. And then postpartum, the uterus is firm and at the umbilicus. I have deceleration on the monitor. And then I have clots and local rubra 2 days after delivery. Bring your content. You can have clots for 48 hours. Therefore, local review is fine. After 48 hours, then you got to worry about it. Early deceleration is usually what? Air compression. Don't worry about it. If the fundus is firm, hey, I'm good. And I'm postpartum right and umbilicus, I'm not going to worry about it. But if I have headache, I have a problem. I got to worry about it. You should worry about it. 14 weeks with severe headache is number one. But all these things are big words you will see. Firm uterus at the umbilicus. By firm, uterus is good. A firm and a contracted uterus is a good thing. A boggy and a big uterus that is above the umbilicus is a problem. Therefore, one is your right answer. Two more. What is your score? Put down in the comments. Let me know. Let me know. What do you think? A nurse is caring for clients who are what? GI patient. Which client the nurse assesses first? Use strategy. Look at the way I'm going to approach it. A client with what? Pancreatitis. I underline the pancreatitis because that's a major problem. What is the issue? Elevated amylase. That's all you need to report about. And he has severe pain. Do you think this pain is going to kill this patient? I have colostomy. I have small bowel obstruction with distension. I just have cholecystectomy and I have shoulder pain. And I have gastroesophageal reflux and I have heartburn. If you have to pick one of this, what do you think? There's a video on YouTube made by me on GI. I talk about all the disease process, easy way to know which one is a prioritization. You should watch it. Check my YouTube channel. But pancreatitis with what? Amylase, elevated. What do you think? Colostomy with what? Obstruction. Cholecystectomy, shoulder pain, GERD, and a heartburn. Which one would you pick? This is prioritization 101. GERD report heartburn after meal. What do you think? That's the definition of what? Gastroesophageal reflux. Don't worry about it. We already seen cholecystectomy supposed to have shoulder pain. Now you're left with pancreatitis with a bunch of amylase and then a severe pain and a colostomy patient, obstruction and distension. If you have pancreatitis, well, you're going to have pain. And if you have pancreatitis, your amylase is going to go up. I don't care about it. We're going to take care of your pain. There's no pancreatitis patients who don't have pain. The only thing you worry about pancreatitis is bleeding. If they have bruising around the frank area and the periumbilical area, this is the content. Second, if they have airway issues, so if they have saturation is going down, that's what you worry about. But apart from the amylase, don't worry about it. That's not a problem. Therefore, colostomy patient who has obstruction is a problem. It can have basically aspiration issue. You can have perforation. We got to take care of the bowel obstruction as soon as possible. So 2 is your right answer. And the last question, what do you think? This is another LPN delegation to summarize it, to put everything together. Once again, MMR most. That's all. MMR most. Most medication, monitor, reinforce, can do some special tests, 2 feeds. What do you think? Multiple sclerosis need assistance with ambulation. Should you think LPN can take care of this patient? Suspected stroke. The word is suspected, presenting with what? Facial droop and slurred speech. Do you think it's okay for the nurse to assign a patient with this situation to LPN? Osteoarthritis requiring scheduled oral pain medication. Can an LPN take care of this patient? A postpartum hemorrhage patient soaking the pad every 15 minutes. Can the LPN take care of this patient? Patient has colostomy, you need a routine stomach care. Do you think the LPN can take care of this patient? And then patient with hypothyroidism who has what? Mesothelioma coma requiring IV levothyroxine. What do you think? put down your answer. Let me know in the comment section. Tell me which one you think the LPN can take care of it. What do you think? Multiple sclerosis just won't work. I think the LPN should be fine to do that. Suspected, that means we've not finished working with the patient and he's presenting. These are buzzwords to tell you initial stroke patient, you need assessment. Does not require the LPN to do that. Osteoarthritis, he has a scheduled medication. Well, the LPN can take care of it. And a postpartum hemorrhage patient is soaking pad every 50 minutes. This is hemorrhage, unstable. This can lead to shock. I don't think we should let them take care of it. Colostomy patient, they can take care of colostomy. Need a routine stomach care. I think it's fine. And if you have mesothelioma coma, yeah, that's not good. That's not good. 11th question, test taking strategy. NCLEX practice question and answers, prioritization and delegation. This is ADAPT NCLEX. Once again, if you want a live class based on the email I got, I'm going to do a class, but I just need to know how many people will come. It's September 13 to 23. You can email me before I set it up because of certain obligation. Take care of you. But if you're one of the people who've been emailing me, well, this is it. If you know about anybody, they can email me. I can do the tally, and then I can let you guys know. Take care of yourself. Good luck. Thank you for watching. This is prioritization. If you need more, I want you to look at Be Sharp on my channel, and you see a bunch of free videos. We teach you. I want to be comfortable to answer prioritization questions. Take care of yourself and good luck in your exams.